Dr. Mohammed Bidewi is going to address us on oocyte cryopreservation. Dr. Mohammed Bidewi is a professor and division head of reproductive endocrinology and infertility department of obstetrics and gynecology, Faculty of Medicine, University of British Columbia in Vancouver, Canada. ما شاء الله يعني double board certified by the American Board of Obstetrics, Gynecology and Obstetrics and Gynecology, Reproductive Endocrinology and Infertility. تفضل دكتور محمد. هتاخد احسن باخده منك.
Well, Bismillah ar-Rahman ar-Rahim. Thank you very much, Mr. Chairman and co-chairs. First of all, I would like to start by saying a great thank you to the organizers for the kind invitation to be part of this meeting. So I'll share with you some clinical tips about oocyte cryopreservation, and I will start with my disclosures, none of which is related to the topic of my talk today. So just go quickly through some of the biological facts that would impact decision-making when it comes to oocyte cryopreservation, and share with you a little bit about the protocols and outcomes and the way we do it, either for planned or social egg freezing or medical oocyte cryopreservation for patients with gynecologic or non-gynecologic cancers who are going for that. And most importantly, actually, just giving you some clinical scenarios on how we should counsel those patients that presents to us asking for either planned or medical oocyte cryopreservation. I want to start with this beautiful image of a Graafian follicle using electron microscope, where you can see the oocyte here in the center surrounded by millions of granulosa cells that has a lot of paracrine, endocrine, and intracrine functions that all work together in synchrony to finalize the maturation of this oocyte, which would ultimately lead to ovulation. And you can see here the ovulation as it happens that was accidentally captured during the time of the laparoscopy that we did in a case. Subsequent to that, actually, the oocyte gets released, and this is a stigma, the stigma of ovulation right here. From this small tiny hole in the ovary, a very important cell will come out, and that is the oocyte. The oocyte, by far, is the largest cell in the human body, measuring approximately 100 micron, with approximately 80% of water content. And that specific feature makes it difficult for oocyte to be frozen. And that is secondary to the fact that cryoprotectants cannot penetrate easily. And there is a calcium release that leads to parthenogenesis as release of the cortical granules, zona hardening, in addition to depolymerization of the meiotic spindle. So it's all about numbers, as I was talking with one of our professors. The entire story starts with 100 primordial germ cells in the yolk sac endoderm that migrates through the roots of the mesentery to the gonadal ridge during embryonic life. And during that journey that takes approximately 14 weeks, they multiply every 18 hours to give to a total of 25,000 primordial germ cells in the gonadal ridge. And that number continues to multiply until it reaches the maximum number of approximately 7 million at 20 weeks gestation. And all of a sudden, there is a drop in the number to the extent that we have only around 300 to 400 at the time of birth and only 200,000 at the time of puberty. And that exemplified by this simple picture that you could see. This is a histology picture of a fetal ovary. And you can see that the ovary is fully studded with primordial germ cells. When you compare that to a 6-year-old ovary, you see the significant decline in the number of primordial germ cells in the ovarian cortex. And look at the adult ovary. Fewer and fewer cells are seen there. So that tells us two important things about the temporal trends of the primordial germ cells. There is a significant decline with age, and there is a significant increase in the percentage of poor quality eggs starting at age 20 that continues to rise until the two curves meet around age 40. So for any woman at age 40, 50% of the eggs are chromosomally abnormal to start with. And that reflects itself in what we see in clinical practice with a significant decline of the pregnancy rate in all of the IVF cycles everywhere in the world, with a significant and incremental increase of the miscarriage risk as the patient gets older. And as we get more informed with the pre-implantation genetic testing of aneuploidy of trophoectoderm biopsies, you could see that there is a significant increase in the percentage of aneuploid embryos, including all comers. It's not only old age, but too young of an age also has a small little peak of aneuploid embryos, and that may explain sometimes the failed cycles in patients who are too young, particularly below the age of 22. So we say in reproductive endocrinology all the time that age is a king. It dictates into us what we are going to do, very much irrespective of the patient age. What I have shown you so far tells us that the oocyte is a very unfortunate cell. It's probably the most unfortunate cell in the human body. Approximately 50% are aneuploid to start with, and 99.9% of the oocyte are destined to die. And by the time the woman reached the age of menopause, only 400 to 500 out of the 7 million that she started with will be ovulating. So that tells us that it's quite important to look into strategies to cryopreserve oocytes, because that is a number that's only on the decline from one day to the next. So there are two types of oocyte cryopreservation according to the indication: the bland, or the also called social, as well as a medically indicated oocyte cryopreservation. And it is no longer experimental since 2012. After reviewing all the data, the SRM lifted the word experimental from the indications of oocyte cryopreservation, which was subsequently associated with increased uptake of oocyte cryopreservation all over the world. And that is because of the great improvement in the oocyte cryopreservation protocols that we use with the vitrification, with the excellent equilibration and vitrification solutions that we use, both in the direction of vitrification as well as in the direction of the thawing when we get to use these oocytes subsequently. So why do women ask for oocyte cryopreservation? We're getting more and more highly educated women, and the more highly educated women, the less the suitable pool of possible husbands. Consequently, the age of marriage is on the rise. History of difficult relationships, in addition to seeing family members struggling with infertility, and some patients desire to have better financial security prior to indicating. In addition to that, many employers now are paying for egg freezing, like Facebook and Apple and other join the line. There is also increased awareness of the negative impact of age infertility, and women want to take charge of their own bodies so they can bank for the future. And there's extensive marketing, which makes it more of a topic in the social media, and alike, consequently, patients go for that. And in Canada, we noticed a significant increase in the number of oocyte cryopreservation cycles after the COVID-19 pandemic specifically. So how do we counsel patients? First and the most important factor is age. And as I said earlier, age is a king. Ovarian reserve comes next. Best markers so far are the AMH and the ultrafocal count. Every patient, irrespective of our age, should be counseled about the risk of aneuploidy. For any number of eggs retrieved, percentage of those eggs, depending on the patient age, will be chromosomally abnormal and would not lead to an embryo ultimately. It's important to ask the patient about what's her planned family size. Does she need 1 child or 2 children or more? And then obviously the regular parts of counseling. Prior to starting the cycle, you should tell the patient how many eggs she would expect from the maximum stimulation that you would get, and also the expected number of children to be obtained per retrieval. More importantly, the use rate of cryopreserved oocytes is still very low. So women have the right to know that she may not need to use these frozen eggs at all, and she may be able to get pregnant on her own when she starts thinking about having a family. The magic question that every woman would ask: how many eggs should I freeze in order to get a reasonable chance of having a child. So the counseling process for that should be dynamic and should be individualized according to many factors. The three factors that I focus on the most when I counsel patients are their age, AMH level, and the desired family size, whether they need one child or more. And actually that classical study is very helpful in the counseling. And that graph tells you the number of oocyte needed if the patient needs one child in blue, two children in red, and three children in green. So if the patient is between 30 and 34, arbitrarily, if you get 10 oocytes, that gives her a chance of 60% to get one child and only a chance of 20% to get two children. So if 20% is not satisfactory to this patient, then from the get-go, on day one of her counseling, you tell her that she needs more than one retrieval. So if she ended up with two retrievals, she will get 20 eggs, which will give her approximately 80% chance of one child and close to 50% chance of having two children. Compare and contrast to a woman who is a 41 coming for egg freezing. If she gets the 10 eggs, that will give her a chance of one child of only around 20% and almost zero chance of having two children. And if she goes for 2 cycles of IVF, that chance of one child improved to approximately 40%, with a very low chance still of 10% to have a second child out of this retrieval. I'll walk you onto how to really personalize it to the individual patient level. This is a patient of mine who is 30 years old, and her AMH is 10.7 picomole, which is equivalent to 1.5 nanogram per ml. For every patient that comes for egg freezing, I show her 3 tables. That is the first table. That is the normogram for anti-Mullerian hormone. So this patient with a 10 picomole per liter, how much am I expecting for her AMH? Her AMH should be around 20 to 22. So actually she is 30 years old. So where is the 10 nanograms here? The 10 nanograms here is at age 38. She is chronologically 30, but from the numbers perspective, based on her AMH, she is actually 38. So that's the first table that I share with the patient. And according to our center numbers, how many eggs we should expect when we stimulate this patient? 10 eggs. So she will end up with 10 eggs per retrieval. And the third table that I share with her is our pregnancy rate regarding our oocyte cryopreservation. So we have 10 eggs in this patient. When we thaw, we lose 2 eggs for the egg thawing, and that gives her approximately 50% chance of one child and around 13% of chance of 2 children. And if she goes for a second cycle, these numbers multiplies with approximately 80% chance of one child and 40% chance of 2 children. So this is just a simple way of sharing with you how we counsel patients about their actual chances. A second patient here who is a 39 years old with a low AMH, and according to the calculations, we're expecting 4 eggs with maximal stimulation, with approximately 18% chance of one child out of that collection. Consequently, she agreed to go for multiple IVF cycles to cryopreserve more eggs at that time. So that's a priming protocol we use based on androgens, actually, because she's a poor responder, and we use maximal stimulation with double trigger in her cycle. We ended up having 4 oocytes. But the patient is facing us all the time. This is really a decent number. If I cannot afford any further cycles, can you tell me more about my chances? One of the things that we started to use lately is artificial intelligence to tell patients about their actual chances based on their AI analysis of the morphology of their oocytes. To simplify it for you, if you look at this metaphase 2 oocyte, what would the best embryologist can tell you about this oocyte? He can tell you that it is M2, good zona pellucida, and excellent granularity of the cytoplasm. So only few data points. If you take the same picture and subject it to AI analysis, that's what you can see. It is the same exact oocyte. So each pixel in this image is a data point that the artificial intelligence can analyze. Consequently, many companies produce many programs that can help the patients to give them more realistic chance, and I will walk you through some of these examples. So for that exact patient, We subjected all the images to the artificial intelligence company. It came back to us with this analysis. It tells us that this patient, out of the 4 oocytes, is expected to have 1 blastocyst, 60% chance to have 1 blastocyst, and 18% chance of having 1 child. And that matches the predicted possibility of having children based on age and AMH. And if you look at the first oocyte on the top here, it has a 40% chance to make it to blastocyst stage. The bottom one has only 10% chance to make it to the blastocyst stage. So the artificial intelligence predicted the live birth rates to be matching the standard of care. This patient, actually, the artificial intelligence predicted the live birth rate to be worse than the standard of care. Consequently, she went for another cycle. And when we subject the yield of the oocyte retrieval here, it was predicted to be better than the standard of care. Just a few examples. How do we stimulate patients for oocyte cryopreservation? You have, as I said, for the bland ones, you have to do the conventional start, mostly antagonist protocol. But for cancer patients, you have no time. So you have to do random start or immediate start, with a focus on maximum ovarian response, safety, as well as convenience. And gene-rich antagonist has been found to be the safest, the shortest, and the most convenient, with agonist trigger for good responders or hyper responders, or double trigger for those who are poor responders. 2 lessons we learned over the time that based on the analysis of 12,000 embryos, there is no effect of ovarian stimulation and oocyte yield in the eubloidy status and the live birth rates of those patients. And the utilization rate of those frozen oocytes remain low at around 10 to 20% so far. This is a cartoon depicting the protocol for an early follicular start, and this is another cartoon about a random start in the luteal phase. The American Society for Reproductive Medicine tells us that both the immediate start protocol as well as the random start protocol are equivalent when it comes to the oocyte yield and the pregnancy rate, with an emphasis that antagonist protocol is probably the way to go for most of those patients. Last question we share with you today, or try to answer, is there a difference in the outcomes between bland oocyte freezing for patients who are not cancer patients versus those who have cancer? This systematic review looked into the data, and they have similar oocyte yield when you stimulate them, either conventional stimulation or a random start when they come into your office. And the utilization rate is still less than 10% for the cancer patients. Oocyte yield is best for patients who are less than 35 of age, and if their AMH is more than 2 nanograms. And there is a high non-use rate of approximately 60% in patients using bland oocyte cryopreservation. So in conclusion, Mr. Chairman, medical and bland egg freezing should be offered where appropriate, and conventional and random start stimulation are equivalent when it comes to the outcome. We have to focus at the time of counseling that egg freezing is not a guarantee for future fertility, and the lady should start trying to conceive on her own whenever possible, first, before resorting to use the frozen eggs. The number of eggs needed to be frozen to achieve a decent live birth depends on the age as well as the AMH. Consequently, more than 1 retrieval may be necessary, and banking oocytes may never be used if the patient gets pregnant on her own. And of course, you have to account for the cost. Thank you very much for your attention.
Thank you very much, Professor Mohammed. The panel is open for any questions.
Thank you very much, Dr. Bidewi, for a genius presentation as usual. I was asking about the role of oocyte cryopreservation in patients diagnosed with ovarian cancer. Do you have special precautions if a young patient is diagnosed with an ovarian cancer?
It depends. So the majority of patients with epithelial ovarian cancer usually get the cancer after the age of menopause and towards the late 40s. So most of the time, those patients are not our target. Our target is mainly for patients who develop ovarian cancer during the reproductive age group, which is mostly granulosa cell tumor that we see the most. And the majority of those cases are diagnosed early and they are unilateral. So most of the time they have the other ovary intact. And if they pass the initial screening period after the surgery, because they don't need staging most of the time, they're good to go. You can stimulate them. So anybody but those with epithelial ovarian cancer, we treat them as if the other ovary is completely healthy.
Is it safe to cryopreserve oocytes or ovarian tissue, even if you are having concerns about this ovary might having hidden malignancy?
So oocytes are different from ovarian tissue. When it comes to oocytes, yes, it is safe if the ovary is cancer-free. Ovarian tissue, it's a different story because you are cryopreserving a big chunk of tissue with subsequent transplantation. So if there is any seeding, or if there is a 10 to 15% chance of bilaterality comes back and hit that ovary, the patient has to be aware of that. One of the temporary measures, you can transplant, do stimulation, and preserve embryos for those patients when they are ready, and you go back and rectomize again if necessary. But that's really rare. We don't see that much.
Concerning Dr. Mohammed, one quick question. Trans-abdominal versus trans-rectal pickup inversion girls.
We don't have that problem where in practice everybody goes for transvaginal retrieval. But for those patients who have ovarian suspensions, we do abdominal retrieval. I don't have any experience with transrectal retrieval myself, so I can't comment. But abdominal retrieval, we do that quite a bit for patients with suspended ovaries or we cannot access the ovary transvaginal.
Okay, we are going to thank you very much, Professor Mohammed. We are going to move to our next speaker, Professor Dr. Hatem Gamal. He's Professor of Obstetrics in HMS University and the head of the Assisted Reproductive Unit in HMS University and the Vice President of the SOGIC. He's going to give us a talk on ovarian hyperstimulation syndrome. Please, sir.
Thank you, Mr. Chairman. Actually, I replaced Professor Mark Brinkett, who was invited to our conference, but for some reasons he cannot come. So I asked me to give a lecture for you, which is not actually prepared. So I choose to supply the ovarian hyperstimulation syndrome. What's about the facts and the solution? It is our nightmare in the IVF. Ovarian hyperstimulation is a syndrome, is an exaggerated response to ovulation induction. So please, I advised you who work in our field in ART not to say for your patients that it is ovarian hyperstimulation. You can say it is exaggerated response. Because hyperstimulation, usually the patient translates that it is your fault, doctor fault. However, the exaggerated response is a patient fault. It is not the doctor's fault. So this is very important when you counseling your patient because these complications is this may occur and they occur a lot in our stimulations. The ovarian hyperstimulation is typically associated with exogenous gonadotrophin stimulation and is rarely observed in the oral ovulation induction. Ovarian hyperstimulation is usually self-limiting disorder. Milder forms resolve spontaneously within few days, but may persist for longer periods and progress to severe disease, especially if conception occur. That is, we have early and late hyperstimulation. Moreover, there is a significant increase in pregnancy-related complications among the patients with OHSS. Therefore, it is the responsibility of the treating physician as to well aware of this iatrogenic disease or iatrogenic disease. So it is important for you to know that how you can prevent and manage its complication. Rates, we have mild ovarian hyperstimulation. About quarter of our patients have a mild hyperstimulation. Moderate, about 7% of our patients, and severe, it is only 0.25%. Mortality rate is about 1 in every, or 3 in every 100,000 cycles. And nowadays, because of our protocols, it changed, and we have the antagonist protocol, the number is decreased of ovarian hyperstimulation. You know the etiology of ovarian hyperstimulation. We have the over-response, we have the overstimulation, and the HCG. These are the factors which affect. We have over-response. Yes, we have patients over-response. Of course, if you PCO, of course, and the overstimulation, if you give a dose not related to the weight and the age. Of course, the dose will be different according to the weight and the age of the patient, and the trigger for the occurrence of the hyperstimulation is the application of the HCG. Pathogenesis of the ovarian hyperstimulation is the vascular endothelial growth factor. This is a cytokine that increases the permeability of the capillaries, resulting an increase in the vascular permeability and shift of the fluid from the intracellular to the extracellular spaces, and this is the most important factor for the occurrence of the ovarian hyperstimulation. So the ovarian hyperstimulation, as I said, vascular endothelial growth factor, increase the capillary permeability, and so the fluid is shifted from the vascular compartment to the extravascular compartment. As a result of this shift, may be so severe, so hypovolemia may occur, and shock. It may the occurrence of low renal perfusion, may occur renal failure, hemoconcentration, and of course thrombosis. Extravascular compartment, increase the ovarian volume, megacystic ovaries, ascites and body edema, abdominal distension and increase in weight, and the pleural effusion, which may be presented by dyspnea. This is the due to shift of the fluid from the vascular compartment to the extravascular compartment. Onset, we have the early onset ovarian hyperstimulation during the stimulation. It occurs within 9 days after oocyte retrieval, or 1 week after oocyte retrieval, correlated to the ovarian response to the exogenous HCG. Late hyperstimulation, it occurs after 10 days of the oocyte retrieval, and it is correlated to the endogenous HCG produced by the implanting embryo in such condition. Clinical presentation, across severity, we have mild to moderate, we have severe, and we have critical form of the ovarian hyperstimulation. The mild hyperstimulation, the patient is presented by the abdominal bloating, mild abdominal pain, the ovarian size is less than 8 centimeters. Moderate abdominal pain, some nausea, sometimes vomitings, ultrasound evidence, mild ascites, the ovarian size less than 12 centimeter. And both we can see in most of our patients, mild and moderate considered, it will be self-limited. Severe ovarian hyperstimulation, this is very important. Clinical ascites, occasionally pleural effusion, oliguria, hemoconcentration is very important to do the CBC and to see the hematocrit is about more than 45, hyponatremia, and the ovarian size by the ultrasound is more than 12 centimeter. Critical form of the ovarian hyperstimulation, tense ascites, the hematocrit is more than 55%, white blood cells more than 25,000, oligomenuria, maybe thromboembolism, and finally adult respiratory distress syndrome, and so both severe and critical ovarian hyperstimulation are managed in the IC units. in the ICU units these forms of hyperstimulation. What are the risk of, who are at risk for moderate and severe ovarian hyperstimulation or severe hyperstimulation? Number one, demographically, age. An increased risk of ovarian hyperstimulation is associated with young age women. Most women who developed ovarian hyperstimulation less than 35 years of age. Most of them, not all, most of them less than 35 years. Body mass index, of course, if we have low body mass index, that is body mass index associated, the lower body mass index associated with more ovarian hyperstimulation, the cause of the infertility, it will differ. If the cause is the male factor and not or tubal factor in the female, it will be markedly different if the cause is the polycystic ovarian syndrome. So these are the demography, the age, increase when the young age, body mass index with lower body mass index, and the infertility cause. If it is polycystic ovarian syndrome, she may develop the ovarian hyperstimulation. Ovarian reserve markers, anti-Mullerian hormone levels with a cutoff of about 3.5 nanogram per ml predict the ovarian hyperstimulation better than age and the body mass index with a sensitivity of 90% and specificity of 81%. So the ovarian markers, we have our ovarian reserve markers, the anti-Mullerian hormone more than 3.5 nanogram per ml, you can predict the occurrence of the ovarian hyperstimulation, and the antral follicle count is again a predictive of the ovarian hyperstimulation if it is more than 24 follicles. If you have more than 24 follicles in both ovaries, so this is predictive of the occurrence of the ovarian hyperstimulation. Ovarian stimulation parameters. Follicles developing, if you have during stimulation, at the end you have 20 follicles or more during stimulation, increase the risk of the ovarian hyperstimulation. Oocyte, positive correlation between the number of the oocytes retrieved and the development of the ovarian hyperstimulation. Retrieval of more than 15 oocytes significantly increase the risk of the ovarian hyperstimulation. The measurement of the E2 concentration significantly associated with ovarian hyperstimulation. The mean E2 value which can predict the ovarian hyperstimulation is more than 3,500 picogram per ml. These are the ovarian stimulation parameters. How we can prevent? So at first, we must detect. We have the demographic criteria, we have the markers, and we have the previous, and we have the ovarian stimulation parameters. And prevention, this is the most important line of treatment. It is difficult to treat. You should prevent. You should try to prevent the ovarian hyperstimulation. According to the SRM, stimulation is making some points to prevent the ovarian hyperstimulation. Stimulation protocol number one, stimulation protocol. There is good evidence to support the use of the ovarian stimulation protocol, GnRH antagonist protocol, in order to reduce the risk of the ovarian hyperstimulation. I think most of the centers nowadays using the antagonist protocol for the ovarian hyperstimulation, for the ovarian stimulation or ovarian hyperstimulation. Use of aspirin, this is debatable, theoretically, increase the platelet activation due to the vascular endothelial growth factor may lead to the release of the substances such as histamine, serotonin, and platelet-derived growth factor that can further potentiate the physiologic cascade of the ovarian hyperstimulation. Based on this theory, aspirin has been considered to reduce the risk of the ovarian hyperstimulation. So if sometimes we apply in the an adjuvant therapy for the IVF, Maybe the aspirin does not increase the results or the success rate of the IVF, but it may help in prevention of the ovarian hyperstimulation. Or use of metformin in those patients with before they are starting the IVF. Again, because we have the androgen priming, is the concept that the androgen increases the ovarian response to the gonadotrophin stimulation by enhancing early follicular growth. So in those patients, the PCO patients, stimulation protocol will be the antagonist protocol. You can apply giving them low dose aspirin, and you can use the metformin during the process of the stimulation. Choice of the trigger for the final maturation, for the minor oocyte maturation prior to retrieve. There is a good evidence to recommend the use of GnRH agonist in antagonist protocols to trigger the oocyte maturation prior to the oocyte, because here we induce the release of the endogenous LH, which have a shorter half-life than the HCG we apply from outside. There is fair evidence that reproductive outcome are improved when low dose HCG said that the trigger with the GnRH antagonist decrease the success rate to some extent. We can apply low dose of the HCG is co-administrated at the time of GnRH agonist trigger for the luteal support. There is insufficient evidence to recommend a lower dose of the HCG for reduction of the ovarian HCC. Dopamine agonist. It is the dopamine agonist, cabergoline. The rule here, it will affect the release of the vascular endothelial growth factor. So it has been postulated that treatment with the dopamine such as cabergoline may result in reduction of the vascular endothelial growth factor production and subsequent reduction in the ovarian hyperstimulation. Accordingly, from the meta-analysis and several randomized trials, there is a good evidence that dopamine agonist administration starting at the time of the HCG trigger for several days. We apply for 7 or 8 days. From the day of the HCG trigger, you can give them the cabergoline. Number 6, calcium. Increase the calcium is postulated to inhibit the cycle KMB stimulated renin serotonin, which decreases the angiotensin II tenses and subsequent effect on the vascular endothelial growth factor. So intravenous calcium infusion on the day of the oocyte retrieval and 2 or 3 days following can reduce the risk of the ovarian hyperstimulation. Number 7, albumin. Of course, the calcium is much better. Albumin increases the plasma oncotic pressure. It may encounter active permeability effect of the angiotensin, and whereas the hydroxyl starch decreases the incidence of severe ovarian hyperstimulation, and this is cheaper than the albumin. And we both nowadays, we don't use the albumin for the prevention of the ovarian hyperstimulation. Costing, we don't, again, we prefer the costing. Costing means that we can withstand the application of the gonadotropin for maximum 48 hours. And this will reduce the incidence of the ovarian hyperstimulation, but at the same side, it will affect the cohort of the oocytes, and we will lose a lot of the oocyte due to costing. Freeze all embryos. This is what we apply. Elective cryopreservation of all embryos and their subsequent transfer in non-stimulated cycle may be used. And finally, cancellation, which is a very bad decision. But sometimes you may need to cancel the cycle. يعني هو الأحسن إن العيانة تزعل أو تعيط أحسن ما أنت اللي تقعد جنبها تعيط. يعني في بعض الأحيان أنا بضطر يعني to cancel ازاي؟ يعني مش هدي انا في هذه الحاله HCG بتاع اللي انا ممكن هديه العيان. يبقى وبناء عليه هعمل ايه الماد؟ نمره 1 stimulation protocol antagonist. نمره 2 I can use the aspirin. نمره 3 في I can use the metformin for those PCO patients. Number 4 the choice trigger will be the agonist trigger. And number 5 dopamine agonist. Number 6 calcium application. No use of the albumin order, no use of the costing, and freeze all embryos and cancellation may occur. So we have 7 steps to prevent the ovarian hyperstimulation, not 10. Recommended metformin co-treatment, low starting dose of the FSH, GnRH agonist protocol, GnRH agonist trigger, avoid antagonist protocol, GS agonist trigger, and avoiding HCG for the luteal phase, of course, dopamine agonist, elective single embryo transfer, and the cryopreservation of all embryos. These are what recommended to prevent the ovarian hyperstimulation. Not recommended the intravenous albumin, not recommended the costing more than three days, using one type of FSH versus another, the same, all the gonadotrophins are the same, the results, lowering the dose of the HCG for final oocyte maturation, using a recombinant LH instead of the HCG. It does not matter, it does not affect. The treatment of the ovarian hyperstimulation, it is difficult. Sometimes, some symptomatic, moderate or severe, or is hypovolemic to a hyponatremic state. Symptomatic, severe, treatment is usually involves fluid replacement to maintain the intravascular perfusion and supportive care. A rare but a life-threatening risk for patients with severe hypovolemia involves the arterial and or venous thromboembolism. Therefore, prophylactic anticoagulation is a must or is recommended in cases of severe ovarian hyperstimulation from the time of the diagnosis throughout the first trimester. Thus, outpatient paracentesis of women with moderate hyperstimulation, moderate to severe, there is fair evidence that to recommend paracentesis or caldiocentesis for those patients. But we don't do here as an outpatient. We do it as an inpatient. Do volume expanders improves the outcome. There is insufficient evidence to support the use of the volume expanders alone for the treatment of the ovarian hyperstimulation. Ovarian stimulation protocols using GnRH antagonists are preferable in women at high risk of the ovarian stimulation. This is grade A recommendation. And the use of GnRH agonist to trigger oocyte maturation, this is again grade A recommendation. Low dose HCG co-trigger, this is grade B recommendation. Dopamine agonist administration starting at the time of the HCG trigger for several days may be used. This is again grade A recommendation. Additional strategies to prevent the oocyte, the ovarian hyperstimulation, the use of the metformin, aspirin administration, cryopreservations, these are. And the mainstay for oocyte treatment includes fluid resuscitation and prophylactic anticoagulation. No rule of surgery, please, except if it is complicated. ده منظر الأوفري. ده منظر الأوفري. اوعوا حد يفتح عيانة هايبر ستيميليشن. خد هيستوري من، وخصوصا لو عيانة جايه لك من دكتور تاني وحضرتك ما تعرفش عنها حاجة وبصيت ولقيت مالتي سيستيك اوفرز ودخلت تفتحها. دي الكوارث بقى. شايفين جيلي. You can take stitches. You cannot take any stitch in this. You can only do surgery in complications. Rupture, torsion, or bleeding. And in most of these cases, the treatment will be oophorectomy of these patients. So please don't open any patient with, she may be complicated with adult respiratory distress syndrome, and she may die from your surgery. Thank you very much.
Thank you, Professor Hatem. We have time for 2 questions only.
I have really one question, please, Dr. Hatem. There has been some studies about that before giving the trigger injection to avoid the hyperstimulation thing, is that we retrieve one ovary and then give the trigger and then
yes.
One.
This is more advanced. I think this I try to be simplified. It's not because most of the attendees not specialists in the but this is of course you are right. You can do this.
Okay, thank you, Prof. Our next speaker is Professor Mohammed Imam. He's a professor of OBGYN in Mansour University. And he will talk to us about 2 decades after the Rotterdam Consensus. Is it still satisfactory?
Bismillah ar-Rahman ar-Rahim. My talk today is about 2 decades after Rotterdam Consensus. Is it still satisfactory? أنا طبعا ببدأ حديثي بالشكر for organizing committee for inviting me for this talk. Polycystic ovarian syndrome is a syndrome resulting from interaction of 5 factors. We should know this. These are genetic, epigenetic, metabolic, and neurologic factor, and also environmental factors. These 5 factors act together to result this syndrome, and the most important of it is metabolic factor. 2 decades after Rotterdam Consensus, the prevalence of this syndrome, it is the most common endocrinopathy affecting women from adolescence to postmenopause. Now, this syndrome can occur in postmenopause according to evidence-based recommendation 2023. And the prevalence is between 10 to 13 about H3 2023. The outlines of my talk includes the following: the background, Rotterdam Consensus 2003, the rationale of my talk, and my objective and source of evidence, debatable pitfalls of Rotterdam Consensus, and my conclusion and recommendation. The background of my talk includes the following: the knowledge base for polycystic ovarian syndrome is rapidly revived and revised. It is not in the story. That's to say, it is a dynamic process. Now there is a creation, debatable pitfalls and controversy. This due to this dynamic process. The diagnosis of polycystic ovarian syndrome according to Rotterdam Consensus include 2 of these 3 items: androgen excess, hyperandrogenism or hyperandrogenemia, oligohyponuria and anovulation, and the polycystic ovarian morphology. I stress here on polycystic ovarian morphology, which differ from polycystic ovarian syndrome. It is one of the items for diagnosis. What is a consensus? Generally, consensus is a political term used only for situation where the science is not solid enough, not evidence-based data. It is according to T. Crichton 1995. And the advantage of the consensus that lead to the diagnosis of the polycystic ovarian syndrome become simpler. No need for a lot of investigation like LH, FSH, and the other. And the debate between ASRAM and the H3 groups has ended from the political point of view only, not evidence-based data. The rationale of my talk is that Rotterdam criteria was based on expert meeting and not on evidence-based guidance with many debatable pitfalls. My objective is to highlight these pitfalls of Rotterdam Consensus after 20 years of application and how to revise it. The source of evidence of my talk include many items: H3 ASRAM polycystic ovarian syndrome from 2007 in Greece, and the 3rd Amsterdam in 2010. Also RCOG 27 guideline PubMed till July 2023, and the personal practice, my personal practice, and now the international evidence-based guidance for the assessment and the management of polycystic ovarian syndrome 2018, and now recently 2023. This is the international evidence-based H3 guidelines 2023, and many data has changed according to this data of this international evidence-based recommendation. The first pitfall of Rotterdam Consensus is the heterogeneous phenotypes. A spectrum exists between isolated polycystic ovarian morphology without clinical or biochemical abnormalities to the full-blown polycystic ovarian syndrome with the clinical and the biochemical abnormalities. This as phenotypes which are after Rotterdam Consensus, 4 phenotypes. These are phenotypes, the number is a full-blown, and the B and C and the T2 of these three items of Rotterdam consensus. The effect of heterogeneity of phenotypes led to controversy of the result of studies and meta-analysis regarding the polycystic ovarian syndrome. The second pitfall is negligence of the polycystic ovarian morphology without syndrome. That to say, what is about if you see polycystic ovarian morphology without hyperandrogenism and without oligohypomenorrhea? It is called asymptomatic polycystic ovarian morphology or solitary polycystic ovarian morphology. It is about 20 to 25 of all women have solitary polycystic ovarian syndrome among the population. So you can see polycystic ovarian morphology without a syndrome. It is very important, and it can lead to many pitfalls, and the consensus of Rotterdam not consider this item. This as a polycystic ovarian morphology was a syndrome, no androgen excess, no, it is eumenoric and the polycystic ovarian morphology alone. That says the solitary polycystic ovarian morphology in this, and the polycystic ovarian morphology issued a recommendation 2018 and 2023. The 8 megahertz new generation sonar, you should have a follicle more than 20 in at least one ovary or at least ovarian volume more than 10 cubic milliliter, cubic cc. Polycystic ovarian morphology issued a recommendation 2023 using the older technology which we have in our clinics, sonar or trans-abdominal ovarian volume more than 10 cubic cc or follicle number per section more than 10. So this is added now by the 2023 recommendation, and you should differentiate this from multifollicular ovary, as the multifollicular ovary can be different from polycystic ovarian morphology, and this is a mistake for many of us. The polycystic ovarian morphology contain multiple cysts, more than 10 follicle within the ovary, cyst diameter from 10 to less than 10 millimeter, and the stroma increased, and reverse this irreversible condition. But the multifollicular ovary, the cyst diameter more than 10 millimeter, and the stroma not increased, and it is a reversible condition. The significance of solitary polycystic ovarian morphology, this morphology may be an intermediate stage between normality and the syndrome. And all cases of this has a luteal phase defect. The presence of this morphology is the core for selection of EXE protocol rather than the syndrome. You should consider this not the syndrome. If you see the polycystic ovarian alone, you should consider it the syndrome during ART under the protocol ovarian stimulation. The third pitfall is negligence of anti-malarial hormone role for diagnosis of polycystic ovarian morphology. Now, in the ISHRI recommendation to 2023, AMH can be used as a strong predictor and an alternative for ultrasound to diagnose polycystic ovarian morphology among women of reproductive age, the adult group. You can diagnose the polycystic ovarian syndrome now by oligohypomenorrhea, hyperandrogenism, and AMH, high MH without sonar in the adult only. But AMH not recommended in adult phenotype of irregular menstrual cycle and hyperandrogenism. This subtype of subphenotype of Rotterdam not recommended here because hyperandrogenism and oligohypomenorrhea can diagnose the syndrome. And in adolescents, ultrasound or AMH are not required for diagnosis of both types. But these are the two types which AMH not recommended for diagnosis. And here you should exclude the mimics of these types, which are 6 types, 6 mimics and 6 differential diagnoses: late onset of congenital adrenal hyperplasia, androgen producing neoplasm, Cushing syndrome, hyperprolactinemia, hypothyroidism, and the ingestion of androgen in the gym and the other athletes. The fourth pitfall is neglect the role of insulin resistance. Many phenotypes of polycystic ovarian syndrome can have insulin resistance or not. The rationale, insulin resistance is inherent in polycystic ovarian syndrome regardless of Benoit's index. That's to say, you can see this insulin resistance in the lean type and obese. In the obese, about 70%, and the lean type, about 30%, and they should be managed early if you detect it. The central player in polycystic syndrome is the insulin resistance. It is responsible for clinical features of ovarian hyperinsulinemia, the only organ in the body which has hyperinsulinemia and insulin resistance is the ovary, but all the body have insulin resistance, and it is responsible for the long-term consequences which is neglected by this Rotterdam criteria. So in the ovary, this hyperinsulinemia, no insulin resistance, occurs the following: stimulate androgen production, impair follicle dominance, premature follicle atresia and ovulation, polycystic ovarian development morphology. And the other organ insulin resistance inhibit hepatic production of sex hormone, globulin, and increase androgen. This how the polycystic ovarian morphology occurred due to insulin resistance. The insulin resistance lead to compensatory hyperinsulinemia, elevated insulin level in the body, and increase the androgen production in the ovary, and the polycystic ovarian syndrome, development of multiple small follicle polycystic ovarian, and the picture of polycystic ovarian morphology. So the insulin resistance is the central player for this syndrome, and it should be managed early. The long-term consequence should be managed and should be early, includes metabolic factor, non-insulin dependent diabetes, sleep apnea, psychiatric, and infertility, and endometrial cancer was very important and can occur in the young age. And if the female become pregnant, there is certain complications that like preeclampsia and the cardiovascular disease complication. The marker of insulin resistance, it is three items: abdominal obesity, and acanthosis nigricans, and the skin tags. Now, the recommendation of ISHRI, evidence-based recommendation 2023, not recommend the fasting glucose per insulin and the HOMA test, and you should depend on available routine measures on this clinical picture. So it is not recommended now to measure to everyone the HOMA test or insulin fasting or the fasting insulin على glucose. The fifth pitfall, it is neglected the difference between lean, which is body mass index less than 25 kilogram per meter مربع, and the overweight or obese polycystic syndrome. Very important because it differs from each other in certain parameter. The lean polycystic ovarian syndrome, the diabetes mellitus, insulin resistant, and the metabolic abnormalities are lower in the lean than the obese, and the insulin resistance is intrinsic only. In the obese, it have intrinsic and extrinsic factor. Visceral adiposity may present, and the prevention of obesity very important in the lean type to prevent the consequence of the complication of this syndrome. The overweight and the obese polycystic syndrome, the insulin resistance is intrinsic and extrinsic. Have two factors inside the body and also intrinsic, extrinsic from the obesity, and should be provided with dietary and lifestyle advice before starting drugs, and this is RCOG 27. The sixth pitfall and the last, not consider adolescent polycystic syndrome as a special entity. So, in the Rotterdam criteria, the rationale, polycystic syndrome presented during adolescence, but not always diagnosed at that age, as the features of normal adolescent development overlap with diagnosis of diagnostic criteria at that age. So, the common features of normal adolescence and the polycystic ovarian syndrome include the following: stress, depression, bad food habits, overweight, obesity, and the lack of exercise in this age, and the psychological effect of acne and hirsutism. So you can mimic each other. It is very difficult, and in many cases are lost at that age. The diagnosis of adolescent polycystic ovarian syndrome, according to ISHRI and ASRAM 2018, include with the following: within 8 years of menarche, this is the adolescent age. Within 2 years, 8 years, hyperandrogenism and irregular cycle. No need for polycystic ovarian morphology because can mimic what is called multifollicular ovary, as we had said before. So you should depend about just 2 items and should do differential diagnosis about 2 items of this. As we said, the 60 factors can occur in adolescent about this age. So the Rotterdam consensus lost the difference between adult and adolescents diagnosis of polycystic ovarian syndrome. Why polycystic ovarian syndrome morphology not essential in adolescent due to the high incidence of multifollicular ovary in this life period. So the multifollicular ovary are occur in this age and they can mimic the polycystic ovarian morphology, so you should not depend on it. My conclusion, Mr. Chairman, the development of Rotterdam criteria was based on expert meeting. It is consensus, not on science, and not on evidence-based treatment guidance. And we are in need for an improved and more reliable multidisciplinary diagnostic criteria of polycystic ovarian syndrome based on a scientific and evidence-based guidance, not political consensus guidance. My recommendation, after 2 decades of the Rotterdam diagnostic criteria of polycystic ovarian syndrome should be revised and revised to consider the following. The item of solitary polycystic ovarian morphology, which is polycystic ovarian morphology without hyperandrogenism and without anovulation, adolescent polycystic ovarian syndrome, and this criteria should differentiate between obese and lean, and insulin resistant or not should be considered. Anti-malarial hormone now should be considered as a marker of polycystic ovarian morphology in adult only, not adolescent, and not of the phenotype of hyperandrogenism and oligohyponuria. Thank you very much.
Thank you very much, Professor Imam. I actually have a question for you. Regarding, I think, one of the pitfalls that Rotterdam's criteria didn't have is that now in PCO patients, we are concentrating more on the hypothalamus, on the neuronal system that is controlling the pulses of the gonadotrophin-releasing hormone, what is known as the Kennedy system, which includes the kisspeptin, the dynorphin, and the neurokinin B.
دي other يعني other pathogenesis. The pathogenesis now is عبارة عن interaction between 5 genetic and epigenetic. This can be called epigenetic for on the gene, and environmental, insulin resistance, and now neurologic. These 5 criteria factor can interact with each other and lead to the syndrome. This factor can be considered on the hypothalamus. It is according to epigenetic factors.
Because recently they say, why is the LH is high? Why the level of the luteinizing hormone is high? Due to the high pulses of the gonadotrophin-releasing hormone. And the reason for the high pulses of the gonadotrophin-releasing hormone is the high level of the kisspeptin, which is released from the hypothalamus.
It is now can be given in hyperexpression syndrome now في حالات اللي هي reliable as a trigger, and it is can be done for ovulation. فthis under trial now under experimenter. It is موجود في ولايه في امريكا وهو ايه like the chocolate of kiss types يعني. Not now recommended and not evidence based.
But I mean الفيوتشر مش هيبقى في موضوع حقن الاف اس اتش والال اتش وكده، الفيوتشر هيبقى في الموديوليشن بتاع النيورونال ترانسميترز اللي في البرين.
انا ما قلتش دلوقتي اي سر على الاف اس اتش والاتش.
يس
وقلت اللي هو ده الايتم بتاع اللي هو روتردام كرايتيريا. ليه هم قالوا روتردام كرايتيريا؟ عشان يمنعوا this over estimation او over investigation، ما عادش لها لازمه خالص. Thank you very much.
Any further questions?
شكرا يا باشا.
Thank you very much. Our next speaker is an old colleague from Ain Shams University, Professor Dr. Muhammad Hussein. His talk is going to be about tips and tricks in infertility management in 2023 update.
ده فورورد وده باكورد. السلام عليكم. طبعا اولا اشكر التشير بيرسون على تواجدهم وتحضيرهم. صعب جدا ان احنا نتكلم بعد قامات علميه عندنا
ولكن احنا هنحاول نقول شويه تيبس اند تريكس، يعني اسئله واجاباتها في الانفيرتيليتي. احنا هنتكلم على اسئله بنتعرض لها يوميا، فاحنا هنسال الاسئله، وكل ما نجاوب اسرع كل ما هنقدر باذن الله نقول عدد اكبر من الاسئله. اول سؤال: هل الانفيرتيليتي مهم زي زمان ولا اقل ولا اكتر؟ ايه رايكم؟ اقل اكتر، نسبه بتزيد نسبه بتقل. هنجاوب according to the WHO قالت السنه دي في ابريل 2023 ان نسبه الانفيرتيليتي بتتراوح في المجتمع من 16 ل 17% according للديفلوبد كانتريز. لو هي highly developed countries 17%، 16% لو هي low income. يعني بيتأفكت 186 مليون انسان، 186 مليون انسان، 48 مليون كابل، وده رقم كبير جدا. السؤال الذي يليه: في تليفون جالي اسمها مدام منى، قالت لي انا والده معاك من 5 سنين، اختي مها متجوزه دلوقتي بقى لها 5 شهور وما حملتش. لو تعرضتوا لهذا النوع من التليفونات هتجاوبوا تقولوا ايه؟ هتقولوا لها ايه في التليفون؟ كل ما هنقول اسرع كل ما هنقول اسئله اكتر. هي عندها 23 سنه ومتجوزه بقى لها 5 شهور واتصلت بيك في التليفون. حضرتك دكتور محمد سلامه، نعمل ايه؟ يعني حضرتك هترد عليها في التليفون؟ هترد عليها، تمام. يعني حضرتك ده كل ده تليفون، هترد عليها؟ المكالمه كانت الساعه 3 الفجر. هنقفل السكه على طول دكتور خالد؟ ايوه انا من انصار نقفل السكه على طول. انا قفلت السكه في وشها وقلت لها ده مش وقت تليفونات، ولو سمحت حضرتك في حاجه اسمها مقابله، عشان انا وقت الفجر ببقى شبه الراجل ده، ما ببقاش عارف مين اللي بيكلمني وممكن اعمل له ايه، ممكن اجاوب اجابات غلط. اتصلت بيا تاني يوم، قالت واحده متجوزه بقى لها 5 شهور وعندها فعلا 23 سنه. دكتور محمد سلامه قال تيجي العياده ولا نديها ميعاد؟ يعني ما تجيش، مش مهم ما تجيش دلوقتي دكتور عبد المجيد، ولا تيجي نبص عليها؟ لازم تيجي، لازم تيجي. دكتور عبد المجيد فعلا قال كلام مظبوط، احنا لازم تيجي العياده. في ماده في القانون ماده 15 بتقول لا يجوز للطبيب الجزم بتشخيص مرض او التوصيه بعلاج من خلال بيانات شفهيه او كتابيه او مرئيه. وانا شخصيا رحت النيابه كتير جدا جدا جدا، وبقول لكم الكلام على الواتساب والمكالمات التليفونيه في منتهى الخطوره. لازم تيجي العياده، عشان كمان في بادي لانجوج، والبادي لانجوج ديت لما تقعد قدامي هفهم منها هل في عندها مشاكل سوشيال، هل مشاكل ميديكال، هل في مشكله وهي داخله ولا لا. فالبادي لانجوج مهمه. جات لي العياده وكشفت عليها، طلعت واحده عندها 23 سنه متجوزه من 5 شهور ما فيهاش حاجه. نعمل ايه؟ نعمل ايه؟ reassurance investigations start of induction of ovulation. دكتور شريف حضرتك تعمل ايه؟ reassurance and nothing. تمام، احنا مش هنعمل لها حاجه خالص فعلا. reassurance and nothing. هتنهار عليك سلسله من الاسئله. اول سؤال: المفروض يحصل انتركورس كم مره في الاسبوع؟ الاجابه كم مره في الاسبوع؟ 2 مرات في الاسبوع. 2 مرات في الاسبوع. احنا كل ما يحصل انتركورس اتليست 3 مرات في الاسبوع، الفريكونسي اوف انتركورس 3 مرات في الاسبوع، هتزود فرصه الحمل ل 50% خلال 6 شهور. فالنصيحه يحصل انتركورس يوم او يوم لا او 3 مرات في الاسبوع، ده اتليست عشان تزودي فرصه الحمل. طيب هل برجع لورا، هل يحصل انتركورس وقت الاوفيوليشن، بعد الاوفيوليشن، بيفور اوفيوليشن؟ الاجابه العروسه بتروح تلاقي العريس قاعد مستنيها في الكوشه. ما ينفعش العروسه تروح تقعد ما تلاقيش العريس. يبقى sperm should be available in the female genital tract at or before ovulation، مش بعد الاوفيوليشن. هتسال بقى نستخدم لوبريكانز انهي وضع احسن؟ يحصل اورجازم او ما يحصلش؟ ايه رايكم الحاجات دي؟ ايه رايكم فيها؟ دكتور كريم بقى السلايد اشيلها. طيب اللوبريكيشن، لوبريكانز دكتور كريم مهم؟ مش هتفرق فعلا، اللوبريكانز مش مهمه. كويتال بوزيشن مهم؟ اي بوزيشن اللي بيحصل لها ريب في الشارع بتحمل، صح؟ الاورجازم مهم. الستات بتقعد من غير اورجازم بالسنين لغايه ما يبقى عندها عيال دخلوا الجامعه وبعد كده تكتشف ان في حاجه اسمها اورجازم وبتحمل. فيميل بوزيشن تنام بعد الانتركورس وترفع رجليها وبمخده وبتاع، راي حضرتك ايه؟ ملوش اي قيمه، صح؟ ملوش اي قيمه، وده فعلا الايفيدنس بتاعه. الغريبه ان العيانه سمعت كلامي وروحت البيت وما خدتش حاجه، وجات لي بعد سنه، استني سنه، جات لي بعد سنه ما حملتش. نعمل ايه؟ دكتور محمد، بيزك انفستيجيشنز، صح. اول حاجه سيمن اناليسيز. سيمن اناليسيز اتعمل، مش عارف هو واضح ولا لا، ولكن انا اختصار للوقت هنقول ان عدد الحيوانات المنويه كان 19 مليون، والحركه 25 على 15، والابنورمال فورمز 25%. لو جالك تحليل سيمن اناليسيز بهذه الطريقه نعمل فيه ايه؟ تمام. انا هبص على الريفرنس هلاقي الريفرنس غريب جدا والريفرنس ده مش مظبوط، صح؟ وبالتالي انا مش هعتمد على هذا المكان اساسا، عشان لا المكان ينفع، اتعمل كام مره، هل ده كمبيوتر اسيستد ولا لا، وبالتالي مش هعتمد عليه. عشان ال WHO ما قالتش هذه الريفرنس. according to WHO 2021 الاخيره احنا السيمن نمبر يزيد عن 16، التوتال موتيليتي تزيد عن 42، والابنورمال فورمز لغايه 96%. ده طبيعي وبالتالي هعتمد عليه. في ديكلاين في الميل فيرتيليتي خلال السنين السابقه، صح ولا غلط؟ اللي بيشتغلوا انفيرتيليتي ملاحظين كده ولا لا؟ يعني تحاليل الرجال عماله تنهار. الكلام ده حقيقه عشان احنا بنتعرض لانفيرومنتال فاكتورز وامراض ولايف ستايل غلط وسموكينج وايجنج وخلافه. هكتب شويه حاجات بارامترز ونشوف هتاثر ولا لا. سن الراجل يفرق في الفيرتيليتي؟ سن الراجل يفرق في الفيرتيليتي؟ دكتوره دينا سن الراجل يفرق في الفيرتيليتي؟ ما يفرقش في الفيرتيليتي. دكتور عبد المجيد عايز يقول يفرق طبعا، يفرق طبعا. الاجابه ان كل ما بيزيد سن الراجل كل ما بيقل الفيرتيليتي بتاعته كسيمن كواليتي اند كوانتيتي. دايت، التغذيه تفرق؟ دكتور مروه التغذيه، اكل الراجل يفرق ولا لا؟ التغذيه تفرق جدا جدا، والبور دايت بيؤدي الى ديكريز فيرتيليتي. شرب القهوه كتير، بيشرب 50 كوبايه قهوه في اليوم تاثر. القهوه سيبيه يشرب، ما بيعملش حاجه، القهوه كويسه. الكحول، يشرب الكحول بيأثر؟ دكتور خالد ما بيأثرش. لا، الكحول حرام، هي بتشرب. الالكحول بيقلل السبيرم فوليوم وبيقلل سبيرم وبيضيع السبيرم مورفولوجي. سموكينج، تدخين، كلنا عارفينها، بتقلل. انابوليك ستيرويدز، بيروح الجيم وبياخد امينو ومش عارف ايه، بيقلل ولا لا؟ بيقلل طبعا. الستريس بيقلل. ماسك الموبايل ليل ونهار وما بيسيبوش من ايده، بيقلل الموبايل. تمام. يعني احدث الحاجات قالت إلا حتى الان لا يوجد ريليشن. تخين جدا وتخن جدا بعد الجواز، وزنه يفرق؟ يفرق جدا فعلا، وفعلا في حقيقه بتقول ان كل ما يزيد في الوزن كل ما السبيرم كواليتي بتقل. الايج بيفرق؟ بيفرق. سموكينج، الكحول وهكذا بيفرق. الاكل ناكله ايه؟ ايه الاكل اللي يفيد السيمن بارامترز؟ اللي كان بياكله حنفي في المسرحيه، البيض والموز والبروكلي والدارك شوكليت والخضروات بتحسن، وطبعا المكسرات بتحسن السبرموفولوجي. نعمل دي ان دكتور خالد، نعمل دي ان ايه فراجمنتيشن روتين عشان نزود فرصه نجاح الاكزي؟ الاجابه لا، خلاص اتلغت الكلام ده، واحنا ما بنعملش دي ان ايه فراجمنتيشن according to the recent evidence الا لو في repeated failure او unexplained infertility، ولكن غير كده ما بنعملش. ملابس الداخليه للرجل تفرق؟ كله قال فعلا تفرق جدا. طب لو يفرق انهي نوع من الملابس الداخليه يلبسه؟ احنا هنقول 1 2 3 4. دكتور شريف رأي حضرتك ايه؟ اقلب السلايد. اقلب السلايد. واحد، ايوه بوكسر. البوكسر اللي هو رقم واحد الواسع ده مش انا اللي قايل على فكره، دي القشري سنه 2018 عامله استادي كبيره جدا وقالت ان الكلام دوت يفرق. الراجل دلوقتي متجوز، دكتور عبد المجيد، الراجل متجوز بقاله 12 سنه، يقول لك ابعد عني متجوز بقاله 12 سنه، مراته بقى عندها 40 سنه، عملوا اكزي كذا مره وما بتحملش. ليه؟ عشان هو عنده سيفير دي ان ايه دامج. فجاي يقول لك انا عملت لها اكزي كذا مره، هتجوز واحده صغيره عندها 25 سنه، نسب نجاح الاكزي هتفرق؟ هي هتتجوز واحد تاني الكبيره. لا هو بقى لو جوز واحده صغيره، الاجابه ايه؟ يتجوز واحده صغيره ولا ما يتجوزش؟ دكتوره هيام، يتجوز. طب ما يتجوزش ليه؟ يتجوز طبعا عشان there is oocyte DNA repair capacity of controlled sperm DNA damage. ولقوا ان الفيرتلايزيشن كان occur with a sperm population with medium and high DNA damage والsubsequent embryo growth affected جدا بسن البويضه، والبويضه تقدر تصلح مشاكل الدي ان ايه بتاعه الراجل according to the DNA. اتجوزها فعلا ومراته حملت وشالت الولد ده وشال الولد ده، هيجي يدخل لك العياده وهو قلقان جدا. الولد ابني ده لما يكبر هيبقى عنده نفس المشكله؟ انتوا معايا؟ اتجوز اللي عندها 25 سنه وخلف ولد ودخل بيه، فبيقول لك دلوقتي ايه؟ النكست بوي هيبقى عنده نفس المشكله ولا لا؟ الاجابه هل هيزود ملوش علاقه اصلا ولا هيبقى نورمال؟ الاجابه according to the issue هيقلل وليه significantly lower sperm concentration and total sperm count مقارنه بالمجتمع، وقالوا ان الكلام ده ليه علاقه بالجينيتكس and epigenetics الظروف المحيطه بهذا المجتمع. عنده فاريكوسيل، يعمل عمليه للفاريكوسيل؟ ما يعملش دكتوره دينا، ما يعملش عمليات للفاريكوسيل نهائيا الا في 3 حالات. لو بالبابل يعني محسوسه كلينيكالي، او لو هي طب هو مش محسوسه كلينيكالي ومتشافه بالسونار ومعاها ابنورمال سيمن، ما يعملش ادام مش كلينيكالي. لا طب لو ازوسبيرميك وعنده اوبستراكتيف ازوسبيرميا ان بالبابل فاليكوسيل وواضحه ومحسوسه، ما يعملش. انت كده هتعمل اكزي وبالتالي ما تعملش وملوش لازمه. يبقى الناس اللي هتعمل هي الناس اللي عندها فقط كلينيكال فاريكوسيل اند نون اوبستراكتيف ازوسبيرميا، لكن غير كده لا ننصح بعمليه الفاريكوسيل. الراجل ده عنده مال نيوتريشن وما بياكلش كويس وما بياكلش كالسيوم خالص. هل الكالسيوم ليه علاقه؟ يعني ممكن يبقى عنده كالسيوم او فيتامين دي ديفيشنسي هو السبب في الميل انفيرتيليتي ده؟ الاجابه عشان الكالسيوم مهم جدا في السبرماتوجينيسيس والموتيليتي. ما اي حاجه بتمشي في الدنيا محتاجه كالسيوم، وكاباسيتيشن اند اكروزوم رياكشن اند فيرتلايزيشن، وده الميكانيزم اوف اكشن ازاي بيؤدي نقص الكالسيوم والفيتامين دي الى ميل انفيرتيليتي. الراجل بقى كويس، نمسك مراته بيزك انفستيجيشنز ايه؟ مراته الست نعمل لها ايه؟ بيزك انفستيجيشنز. تمام ماشي حلو قوي. يبقى احنا اول خطوه هنتشيك تيوبس. هتقول لك ايه يا دكتور؟ انا قرايبي اللي عملوا اشعه صبغه حملوا. اشعه صبغه بتحمل؟ بتزود فرصه الحمل؟ الإجابة according to the Cochrane review yes there is increase and significantly higher pregnancy rate after hysterosalpingogram بغض النظر عن كانت water soluble ولا oil based media. نعمل لها TSH. المفروض TSH للوحدة اللي عايزة تحمل يبقى 2.5 اقل من 2.5. دكتور كريم طبعا، الدكتور كريم هو اللي علمني اصلا هو according to the American سوسايتي لازم يكون التي اس اتش اقل من 2.5 فعلا according to the American Society. هنتشيك الاوفيوليشن. اهم طريقتين نتشيك الاوفيوليشن هما ovarian reserve and antral follicle count. عندنا مشاكل كتير بتؤدي لهايبو اوفيوليشن. اهم مشكله هي البي سي او. بي سي او طبعا ده سندروم كبير جدا، ولكن احنا هنعديه عشان نسال سؤال. لو العيانه ما بيجيلهاش دوره ومتجوزه بقى لها 5 شهور وبي سي او، اديها ما بيجيلهاش دوره، اديها اندكشن ولا ما اديهاش؟ اديها. الاجابه according للهيومن ريبرودكشن ابديت في فرصه نجاح ان انت تحملي خلال السنه دي 8.5% spontaneous pregnancy rate without induction. استني السنه، مش عايزه استنى او عدت السنه وما حملتش. The first line of treatment of PCO patients is weight reduction, and the first pharmacological line of treatment is pharmacological دواء is رقم 5 لتروزول. لتروزول هو الفيرست لاين اوف تريتمنت. امال الميتفورم اللي احنا عمالين نديه عمال على بطال ده ايه؟ فقط في الميتابوليك فيتشرز، ولكن ما ندوش عمال على بطال. الدريلينج ليه دور اكوردنج للابديت دلوقتي ليه دور، وده الابديت الاب تو ديت. قال الفيرست لاين هو الويت ريدكشن فارماكولوجيكال لتريزول، يليه اف اس اتش واوفيريان دريلينج، ويليه الاي في اف. فالاي في اف بنسيبها في الاخر. خلي بالكم هو قال الاي في اف في الاخر ليه؟ عشان لو خدنا بالنا قال لك فيري هاي كوست. هل الاي في اف كوست دلوقتي؟ الحقن المجاري دلوقتي مكلف جدا. اكورد في السنه دي الاحصائيات اللي اتعملت قالت ده سيستماتيك ريفيو على فكره ان الحقن المجاري بيكلف في اقل دوله في العالم $2100 وممكن يوصل ل $19,000. $2000 في مصر يعني حاجه و80,000 جنيه. طبعا احنا من ارخص الدول في العالم. لو انتم شايفين ده الكوست على مستوى العالم، هتلاقي مصر صغننه تحت خالص في اقل دول العالم في الكوست بتاع الاي في اف. احنا تقريبا ارخص دول. هنديها لتروزول، فهتقول لك يا دكتور انت هتديها منشط، هتخلص البويضات بتاعتها، هتخلص according to the recent studies. عملنا 4 دورات حقن مجهري متتاليه ما اثرتش الاندكشن اوف اوفيليشن على عدد البويضات، ونشرح لها الموضوع تم ليه. الليتروزول طبعا كان بيستخدم في البريست كانسر في الاول، وهو دلوقتي كومبارابل جدا واحسن من الكلوميفين ستريت، عشان الكلوميفين ستريت ده بيسموه ذا ديسيفر، الخادع، بيطلع بويضات ولكن الست ما بتحملش، نتيجه ان الكلوميد بيقعد شغال 2 أسبوع فبيفضل اف اس اتش بتاع العيانه عالي فبيطلع كذا فوليكل. اما الليتروزول بيفضل شغال فقط لمده 2 يوم. عشان الوقت. اندومتريوزس جولد ستاندرد فور diagnosis for endometriosis is clinical ولا منظار؟ clinical ولا منظار؟ دكتوره هام. clinically هو the gold standard for diagnosis. الناس اللي عندها ديسيوريا وديسمينوريا وديسبارونيا، وفي بنات بيبقى عندهم حاجه اسمها كاتامينيال نيموثوركس، اللي هو كل شهر في ميعاد الدوره تفرقع اللنج عندها وتطلع دم جوه البلورا وتدخل تتحجز، ولازم تتركب انتركوستال تيوب والا هتموت. وكنت انا موفق ان انا بالتعاون مع الكارديو سيرجن عندها في جامعه عين شمس نشرنا سيستماتيك ريفيو اند ميتا اناليسيس في اليوروبيان جورنال بتقول على دور الهرمونال تريتمنت بعد السيرجيكال اكسجن اوف كاتامينيال نيموثوركس، وده السيستماتيك ريفيو اللي احنا نشرناه. سي 125 ما مش تستخدموش الا فقط فور تشيك للسيفيريتي لكن مش في الدايجنوزس. اشتغل اندومتريوما قبل الاكزي، اشيلها ما اشيلش اندومتريوما قبل الاكزي الا لو في حالتين. لو انا مش قادر اوصل للفوليكلز او العيان عندها بين فعلا، ساعتها لازم نعمل سيرجيكال تريتمنت. ساعتها نشيلها ولا نفضيها؟ لو انا هدخل سيستكتومي نشيلها مش نفضيها. طب جت بنت صغيره عندها 16 سنه وعندها اندومتريوزس، والاندومتريوزس دوت واصل لغايه المنظر ده. دي عيانه جات لي في العياده على فكره، والاندومتريوتيك شوكليت سيست واصله فوق الامبليكس. العيانه دي المفروض نعمل لها ايه؟ 16 سنه انسه. هنعمل لها ايه؟ هنعمل لها منظار according to the ISHRI guidelines. نعمل لها منظار. ده بطنها، شايفين بطنها عامله في ازاي فوق؟ عنيفه جدا. وده منظر، وده according للISHRI guidelines قالت ان هو ده اللاين اوف تريتمنت، لكن لازم يكون very experienced surgeon ولازم يكون لاباروسكوبي مش لاباروتومي. وبالتالي فايبرويد، لو واحده عندها فايبرويد نشيله ولا ما نشيلوش؟ لو صاب ميوكس او انترستيشال اكتر من 5 سم نشيله، ولكن اكتر من كده ما نشيلوش. وطبعا عشان الوقت بتاعنا خلاص انتهى، فانا طبعا اخر حاجه لو العيان عندها اوفيريان هايبر ستيميوليشن احنا بنخاف من انها تموت، وفي الاخر هنديها كالسيوم عشان ما تموتش زي ما الدكتور حاتم قال من شويه. والتيك هوم مسج، احنا لازم نوصل للبيبي بالليست تايم ستريس اند ماني، واحنا لازم نعمل كل اللي نقدر عليه عشان ربنا يعمل اللي احنا مش قادرين نعمله. وورا كل اللي احنا بنقوله دوت، ورا كل المشاكل اللي بنقابلها هيبقى فيه هابينس كبيره جدا انها تجيب بيبي. واحنا مهما اتكلمنا والحياه خلصت، النولج عمرها ما هتخلص and the knowledge is infinite. ونهتم بالكواليتي اكتر من الكوانتيتي، وفي الاخر بتحمل بفضل ربنا مش بشطارتنا. وشكرا جزيلا ليكم.
نشكر الدكتور محمد حسين على very unconventional presentation. The floor is open for the 2 questions. تفضل.
خمس شهور منهم؟ لا ده سوشيال، يبقى لازم نشوف العيانه دي سوشيال. هبتدي انفستيجيت.
نبدا اندكشن معاها ولا
انفستيجيشنز.
لو حضرتك قلت الفيميل اورجازم مش مهم، طب الميل اورجازم؟
الميل عمره ما هيحصل ايجاكيوليشن الا بعد الاورجازم، فعشان يحصل ايجاكيوليشن لازم يكون حصل اورجازم. Yes, of course. In which patient؟ في العيانه الانفيولاتوري. ايوه طبعا.
لا انا بتكلم على عيانه 5 شهور زي كده، انا ليه ابدا معاها اندكشن؟
انا ما قلتش نبدا اندكشن.
اعمل فوليكولومتري.
انا قلت بيزك انفستيجيشنز and wait for 1 year. لو هي unexplained infertility yes there's rule of induction of ovulation in unexplained. يعني لو كل حاجه طبيعي هتديها induction عشان هي unexplained plus or minus IUI، وفي الاخر لو ما حملتش بتعمل اكزي.
طب في الانكسبليند الاندكشن في عيانه اوفولاتر اصلا هيزود الشانس بتاع البريجنسي؟
In unexplained yes of course it is one of the lines of treatment. عشان انت بتزود نمبر الفوليكلز الافيلابل للسبيرمز، فبدل ما يبقى فيه 1 فوليكل افيلابل للسبيرم 5 6 7 فوليكلز، وبالتالي there is a higher chance of pregnancy. كانك قعدتها كذا شهر 7 شهور ورا بعض، انت اديتها في شهر واحد 7 فوليكلز.
Okay, thank you very much.
شكرا.